Good evening, everyone. Today's session is going to be really helpful and is led by Dr. Tina. She is going to talk about hypertension in pregnancy. So stick around until the end and ask us questions if you have any. Let's not keep you waiting any longer. Doctor, you have the stage.
Good afternoon, everyone. So, today we are going to talk on hypertension in pregnancy. Now, hypertension in pregnancy is one of the most common complication that we see during the pregnancy. It is one of the reason of very high morbidity and mortality to the mother and baby. So, the not only causing deaths but also affecting it otherwise to the mother and baby. So now, usually hypertension in pregnancy will not come to everyone. It is usually there when there is a toxemia or some underlying toxic condition is already present, which may be a pre-existing condition or first time during the pregnancy. So it is one of the toxemias of pregnancy, the hypertension. So it can be a pre-existing or one which comes during the pregnancy. Now, what is hypertension? Hypertension is any blood pressure which is more than or equal to 140/90. 140 being the systolic blood pressure and 90 being the diastolic, which is the down. 140 is the on top and 90 is the down. So either it can be that any consecutive two readings of more than 140 equal to or more than 140/90 is what is called hypertension. Now, also, there can be patients who have very low blood pressure, starting only their blood pressure maybe 80/50 like that. So, there is another definition of hypertension wherein the upper BP, that is the systolic blood pressure, is more than increases by more than 30 during that tenure, or the diastolic blood pressure, that is the blood pressure which is below, increases more than 15 during that tenure. So, one more anything systolic more than 30 and diastolic more than 15 difference is hypertension, or two readings of 140/90 and above is again hypertension. Now, hypertension in complicating a pregnancy can be an incidence of around 10%. The prevalence rate is 6 to 8%, but complicating pregnancy is around 10%. Now there are different types. Okay, before we come on to the different types of blood pressure, what are the risk factors? Why, in whom we see blood pressure more? So the risk factors leading to blood pressure can be number one, first pregnancy. First pregnancy is itself a risk factor. Nulliparous can be itself a risk factor for hypertension. Number two, previous pregnancy with blood pressure. Number three, age more than 40 or less than 18 years. Number four, family history of any pregnancy induced hypertension. Number five, chronic hypertension, already a patient of hypertension. Number six, chronic renal disease, past history of any kidney disease. Number seven, APLA syndrome or the blood clotting syndrome. Number eight, it is comorbidities present like diabetes mellitus. Number nine, multiple pregnancy can be one of the risk factors. Number 10, an increased BMI or obesity can be one of the risk factors. Number 11, male partner with the first wife having a pregnancy induced hypertension. So the second wife also has higher risk. Number 12 is any abnormality in the fetus like hydrops fetalis. Last is the unexplained intrauterine growth restriction of the baby. So these are one of the risk factors which can give rise to hypertension in pregnancy. Now, hypertension in pregnancy is classified into many types. One is a chronic hypertension. Chronic hypertension is when the blood pressure is present before she is pregnant or before 20 weeks of pregnancy is chronic hypertension. Or it can be preeclampsia. That means the hypertension comes in after 20 weeks of pregnancy. It can be, third is chronic hypertension with superimposed preeclampsia. That is, she's already having hypertension on treatment, and now with pregnancy after 20 weeks, preeclampsia also comes in. Fourth is gestational hypertension. Gestational hypertension is pregnancy hypertension, but does not have any that is gestational. Third is transient. Fifth is transient hypertension. Transient hypertension is when there is a small rise in BPA for some weeks and then it settles down. Sixth is a complication of pregnancy, hypertension or preeclampsia, which can be HELP syndrome or it can be eclampsia. HELP syndrome is when there are a lot of bleeding parameters, they are affected and has lot of bleeding, or it can be eclampsia, that is fits to the patient, convulsions or fits in pregnancy due to blood pressure. So these are the features of types of classification, types of hypertension in pregnancy. Now, when we do types, we will start from chronic hypertension. So, any blood pressure which is high in a pregnant woman before she turns 20 weeks, or it is present after 12 weeks of delivery, both are chronic hypertension. When the blood pressure is comes up before 20 weeks of pregnancy or after 12 weeks of delivery, either one can be this chronic hypertension. So how it affects the pregnancy? In all the hypertension, the basic thing is there are certain risk factors to the mother, and to the baby it is always intrauterine growth restriction or intrauterine fetal death. So how do you investigate that chronic hypertension? Now a patient has come before pregnancy, she has blood pressure, or first 20 weeks only she is diagnosed with blood pressure. Now you do your blood, so we need to do blood test to find out how bad the blood pressure is already affecting the mother. Certain urine test, blood test to see the kidney profile. To we also have to rule out that is there any other pre-existing kidney disease which is causing the hypertension, or any other comorbidities which are associated with hypertension at that point of time, and to see whether she is discharging protein in the urine. So, how much protein is coming in the urine? Usually, chronic hypertension will not discharge much protein during the first half. Once they are superimposed with the pregnancy induced blood pressure, that is when the proteinuria starts in the urine. How do you treat? Treatment will be giving keeping them on antihypertensive drugs, and observation on how the pregnancy manipulates and how it works through. Now the patient may come up with a previous hypertension before she is pregnant only, and she must be in a certain drugs maybe at that point of time when she is planning pregnancy, or when she's already pregnant. You should have to be shift to a antihypertensive drug which is safe for the mother and the baby. So appropriate use of correct antihypertensive drugs have to be used, and continued pregnancy. Counsel her for what are the risks of chronic hypertension to both the mother and the baby. Baby, we are looking into intrauterine growth restrictions, and there can be a preterm delivery, prematurity. So these has to be looked into and counseled properly during the tenure of the pregnancy, and the patient has to be monitored. The patient has to be monitored regularly for her blood pressure changes, for any changes in the blood workup or the urine workup which may be coinciding with hypertension in pregnancy, and to appropriately treat her with antihypertensive tablets and drugs, and monitor her, the baby, also with serial growth to see if the growth of the baby continues to be normal. So this is chronic hypertension. Intervene, you have to intervene when either the blood pressure is going out of hand, or or how it is affecting the baby. If the baby is getting affected, growth is retarded, or the blood flow to the baby is affected, in all such cases, we may have to intervene and cut short the pregnancy. At any point we see that the pregnancy has gone on to the stage when the baby can be brought out and managed outside without any risk to the baby. But at any point of time, the mother's life is more important, so depends on how bad the hypertension is affecting. Usually chronic hypertension will do well till there is the third type of hypertension comes in, that is chronic hypertension with pregnancy induced hypertension. Now the second type of hypertension which we are going about talking is preeclampsia. Preeclampsia or pregnancy induced hypertension. Now preeclampsia is a blood pressure increasing after 20 weeks of pregnancy. So that means that till weeks the patient was normotensive, nor and there was no protein release in the urine. So non-proteinuria and non-normotensive previous patient with a history of hypertension beyond 20 weeks comes into the preeclampsia category. A wide range of patient comes into this category from 5 to 15%. Those patients who have chronic hypertension can superimpose with such hypertension to almost about 25%. Okay, now preeclampsia will have certain pathophysiology behind it. So the pathophysiology can be that the inappropriate migration of the placental cells during the formation of the placenta. So the uteroplacental bed may have not formed properly, or how in medical term we say the migration of the placental cells are abnormally happens around 12 to 14 weeks and around 16 to 18 weeks. So these are the two times when cytotrophoblast migration happens, and when the uteroplacental bed is not formed properly or there is some problem in that, that is one of the pathophysiology. That means that underlying problem is there, or some immunological factors. So there are hormones, enzymes like hormones like prostaglandins or other hormones which increase. So they are hormones which they cause vasodilatation, which are more in a normal pregnancy, and the thromboxanes are there, TAXAs. The thromboxanes are cause more of vasoconstriction. So these these are the immunological factors, the prostaglandin and the thromboxanes. So when both are there increased in pregnancy. Now when in a normal pregnancy, the prostaglandin will have the more effect, so there is vasodilatation. Okay, so enough blood flow and blood supply, the dilation of the vessels and everything happens good. In a case of pregnancy induced hypertension, the thromboxanes will be more, so there are more vasoconstriction and thinning of the blood that causes all these problems. So this is immunological factors. There can be genetic factors when there is a history of sister or mother or family history. So it is said that if norm if a person's if the patient's mother or sister had pregnancy induced hypertension during her pregnancy. So if the mother had pregnancy induced hypertension during her pregnancy 30 years back, 20 to 30 years back, then the daughter has 8% more 8 times more chances of getting pregnancy induced hypertension other than the normal person. So 8 times more risk. So that is the genetic condition which causes this type of preeclampsia. How do you diagnose preeclampsia? So preeclampsia is blood pressure is more 140/92 readings of 2 or more readings of 140/90 and above blood pressure. That is blood pressure is more. Second thing is lot of swelling in the legs. Though swelling in the legs can be present without hypertension or with hypertension. So in pregnancy, if there is lot of swelling in the leg, then we have to rule out hypertension before uh, we confirm that swelling is not because of if the blood pressure is lower side of normal, or it is normal or less, then swelling is part of the weight gain of pregnancy or the weight bearing of the pregnancy to the legs. But if the blood pressure is high, then the swelling has to be taken care of and appropriately monitored. Then third thing is proteinuria. So as I told you, lot of protein release in the urine. So otherwise also sometimes protein release happens in the urine. So with a low blood pressure, proteinuria is normal at times, but with a blood pressure high, the proteinuria is significantly the reason for with preeclampsia and needs to be monitored. Now, so hypertension, swelling, pedal edema or swelling, and proteinuria. These are the diagnostic conditions of finding out that there is pregnancy-induced hypertension. Now, that is preeclampsia. Preeclampsia types in pregnancy can be mild or severe. When the BP is maintained 140/90 and controllable with tablets, and the proteinuria in the urine is less than 2 2 plus, so either it will be nil, 1 plus, 2 plus, 3 plus, and 4 plus. So anything less than 2 plus protein in the urine, swelling can be there, and a blood pressure maintaining 140/90 and less with antihypertensive medications. This is mild preeclampsia. In a case of severe preeclampsia, it is when the BP is more than this, or a proteinuria or 2 plus and above, is called severe preeclampsia. Severe preeclampsia may be associated with other complications of pregnancy, which we'll come to later. So, what are the clinical features when you see a preeclampsia? Clinical features can be swelling, as I told you, pedal edema. There can be headaches, frequent headaches because of blood pressure. There can be decreased sleep. There can be decreased urine output. The urine output has to be monitored. There can be epigastric pain, so just below your chest, upper part of your tummy, epigastric pain can be associated problem. There can be blurring of the vision. So if there is blurring of the vision with epigastric pain and vomiting and all, it has to be immediately looked into. It's an emergency. But otherwise, a patient may come with swelling, headache, lack of sleep, decreased urine output. These are all findings of preeclampsia. What are the signs of preeclampsia? Can you hear me now? I hope you can hear me. So, abdominal weight gain, increased blood pressure, swelling in the legs, these are all signs of preeclampsia and needs to be monitored. How do you investigate and follow up a patient of preeclampsia? So, for investigation, there is proper blood and urine test needs to be followed up. So you need to be sure about the liver toxicity, the renal toxicity, her hemoglobin concentration, whether there is thickening of the blood or dilution of the blood. So on those blood parameters, mm, and in case it is going into a severe preeclampsia, you need to monitor her fibronectin levels and lot of blood disorder levels, bleeding profile. All these needs to be monitored. Otherwise, it is the basic parameters that needs to be checked. Now, urine albumin has to be carefully and frequently and regular intervals checked for. Then her coagulation profile to be checked for. Then her retina, the BP, blood pressure can always affect the eyes. So retinal damage or the needs an ophthalmology opinion to look into the retina. Her blood monitoring, which includes the renal and the liver profile, her regular hematology, CBC, and blood clotting profile, the coagulation profile. Then liver enzymes need to be checked. Then her urine albumin and her retina, eyes need to be monitored. This is for the mother. For the baby, you need a proper kick count to explain that she has to monitor the kicks of the baby, the kick count examination, counseling, regular interval check to see that the growth of the uterus is happening normally. Third, the ultrasound checks, regular growth scans to be done to see the growth of the fetus. The water level need to be checked. AFI check, the Leica pockets to be checked during the growth scan. The blood flow, umbilical artery blood flow need to be checked on the scan to see if there is any Doppler changes which are coming in, which may affect the baby, and how fast or later we need to deliver the baby. So the Doppler scans need to be checked. The baby's well-being profile, that is the biophysical profile, can be checked. So these are the follow-ups on the baby. That is the kick count, the interval check of by the doctor for the uterine growth, the ultrasound to check for growth scans, water level to be checked, umbilical artery Dopplers, and the baby's well-being profile. What are the complications that we come across in preeclampsia? So the complications that we come across, the first and the foremost and the most important is eclampsia, that is convulsions. So eclampsia convulsions can yet the complications are in the term of maternal complications. So the maternal complication can be eclampsia, that is convulsions, need to be treated immediately. So the other complications are uh, antepartum hemorrhage or postpartum hemorrhage. So before the delivery, any bleed, or after delivery, heavy bleeding. Then uh, eye damage, retinal damage, then renal problems, renal damage, decrease in urine output, needing acute renal failure or chronic renal failure, then preterm delivery, prematurity and preterm delivery, then HELP syndrome, the patient going into certain bleeding profiles, problems where the enzymes, liver enzymes are very high, the platelets come down, hemolysis happen. So this is HELP syndrome, which is a medical emergency for the mother. Okay, there can be cerebral hemorrhage. The blood pressure may shoot up at intervals high, such that she may land up into a hemorrhage in the brain vessels, cerebral hemorrhage. Then the risk to the maternal lungs, called adult respiratory distress syndrome, so the ARDS. So these are the complications which we come across to the mother: eclampsia, hemorrhage, which can be antepartum or postpartum. There can be retinal damage. There can be renal damage, preterm labor, cerebral hemorrhage, HELP syndrome, and ARDS. To the fetus, it can cause baby. It can cause sudden intrauterine death. It can cause intrauterine growth restriction, which may be immediate, may requiring immediate action. There can be asphyxia to the baby and prematurity to the baby, requiring an ICU deliveries and ICU care and further management. So these are the thing. How do you predict? Usually prediction is only by BP checkup and blood and flood, the Doppler scans on the for the baby, the blood pressure for the mother, and the urine albumin for the mother, and the Doppler scans for the baby is how you predict that whether the preeclampsia is going into a condition of any complication. Now, how do you prevent it? Prophylaxis. Prevention is number one is proper antenatal management. So in all high risk cases for blood pressure management, first thing is close follow up for the blood pressure and urine albumin, and second thing is aspirin. Aspirin is a low dose aspirin is used, and evidence based medicine says that low dose aspirin is used in the treatment of to prevent hypertension and growth restriction in the baby. There is no role of low molecular weight heparin injections unless it is proved that there is some blood clotting disorder in the mother. Unless and otherwise, there is no role in hypertension in pregnancy and growth restriction to the baby. So these things don't have a role. Now, only low dose heparin is the treatment. Curative treatment of such cases is finally delivery. So till delivery, you manage with antihypertensive drugs. In case of severe preeclampsia, when the blood pressure is becoming very high and the patient is going out of control, magnesium sulfate is a drug of choice to prevent eclampsia, that is convulsions or fits. You can also the treatment of eclampsia again becomes magnesium sulfate when the patient is already thrown a fit. So proper management, urine albumin detection, low dose aspirin, antihypertensive drugs. You can have two drugs of antihypertensive simultaneously at the same time. Frequent monitoring of the pH profile to see if anything abnormality or increasing. Keep your eyes open for any complications that is going to land up. Then proper antenatal checkups and BP monitoring. Then antihypertensive drugs, correct use of antihypertensive drugs, appropriate timely use of magnesium sulfate in case of indication of convulsion or convulsion, and delivery. So finally, delivery is the treatment of pregnancy induced hypertension or preeclampsia. Now, last thing is eclampsia. Eclampsia, as I told you, that it's a convulsion which comes in. You have to treat with magnesium sulfate and terminate the pregnancy then and there if the patient lands up into eclampsia. So correct the patient and make the patient active, away from danger, and immediately deliver the baby. Now, delivery of the baby at any point in hypertension in pregnancy can be, one thing is a maternal reason for whatever. If it's a mild hypertension or blood pressure, she can go in for a trial of labor and deliver normally if it works out. In case of a severe hypertension, if it is picked up early and management, you can give a trial of labor. But in a severe preeclampsia with imminent eclampsia, or in cases of eclampsia, a vaginal delivery trial may not be feasible and an elective C-section needs to be done. So that is the method of delivery of the patient. Then during that delivery also, during delivery, BP monitoring and other parameters of blood and urine needs to be monitored and looked in and assessed for any imminent fits or eclampsia is going to come in, and appropriate use of drugs. After the delivery, it is seen that eclampsia is more common after delivery in a case of severe preeclampsia. So postpartum also, post delivery also, it is very necessary to monitor the patient to rule out any severe preeclampsia which is coming in, or a blood pressure is increasing, or she's going into eclampsia, that is convulsions. Also needs to be monitored for HELP syndrome, whether her liver enzymes are getting low, or elevated liver enzymes or low platelets. So these HELP syndrome, so that she doesn't go into bleeding. So HELP syndrome and preeclampsia should be monitored very closely for the 24 hours post delivery. If you feel anything like this is coming up, then prophylactic magnesium sulfate can be given for 24 hours post delivery. And if antihypertensives can be restarted immediately post delivery and monitored. Active management of the third stage of labor, that is immediately after delivery, active management should be done to prevent any heavy bleeding. So postpartum hemorrhages are very common, needs to be assessed and checked. So this is how. And then post, after 24 hours, when she is settled down and she is fine, you need to be putting her on antihypertensive drugs for a minimum of 2 weeks, and then monitored, and can go up to 6 weeks as required. Multidisciplinary help can be required in such patients with a, as I told you already, ophthalmologist. We may need a physician, we may need a cardiologist, we may need an anesthetist and ICU in charges to help us go through this pregnancy very nicely. So this is hypertension in pregnancy, which is a very important factor. We need to monitor it properly, and once monitored properly, usually we can take care of the pregnancy appropriately and nicely. We cannot prevent, we can delay a complication which can come, which may be going to come in, and also timely act before an active complication comes in and take care of the mother and the baby. So that is all about hypertension in pregnancy. Thank you for patient listening. If you have questions, I will be ready to answer the questions. Sai, come.